Hi everyone, welcome to Breast Cancer in Young Women, What You Need to Know webinar, proudly organized by Thomson Breast Center and Icon Cancer Center, supported by our event partner, Pfizer. My name is Kelly and I will be your host for this webinar. Thank you for taking time to join us on this wonderful Saturday afternoon. We promise that it will be worth your time. Now, besides the informative sharing by our breast cancer specialist today, feel free to, we have also arranged an interactive Q&A session for your participation after the sharing by both our specialists. So feel free to key in your questions at any point in time in the Q&A box that you see at the bottom row of your Zoom screen, all right? We will be doing our best to address your questions during the Q&A session after our panelists sharing. Now, to put things into context on the topic of breast cancer in young women, well, younger women below the age of 40 are generally do not consider themselves at risk of breast cancer. However, it can actually strike at any age. Now, according to the Singapore Cancer Registry 50th anniversary monograph published last year, breast cancer remains the leading cancer among women in Singapore. Between 2013 to 2017, nearly 6 breast cancers were diagnosed daily. Now, although the disease tends to affect older women, 1 in 6 of these diagnosed cases is younger than 45 years old. The good news is, however, effective treatment is available for breast cancer if it is detected early, making regular screening a very important component in increasing the success rates of treatment and recovery. In today's webinar, we will be providing you with insights on how you can detect breast cancer early, treatment options that are available for younger women, as well as address your concerns on fertility preservation. It is now my pleasure to introduce our panel of breast cancer specialists for today. We have Dr. Tanya Swam, breast surgeon and clinical director of Thomson Breast Center, as well as Dr. Guek, senior consultant, medical oncologist at Icon Cancer Center. They'll be speaking on the topics of breast cancer in young women, how to screen, special considerations for surgery, as well as breast cancer with a focus on young women and fertility preservation. Once again, if you have any questions during their presentation, please feel free to key them into the Q&A box, and we will do our best to address them during the Q&A session after both our specialists have presented. Without further ado, let's welcome our first speaker, Dr. Tanya Swam. A brief introduction about Dr. Tan. Hi, Dr. Tan. I'm going to wave to the camera. So Dr. Tan is the clinical director of Thomson Breast Center. She's an accredited general surgeon with a special interest in breast surgery with more than 15 years of experience caring for patients. Now, prior to private practice, Dr. Tan has looked after patients in Singapore General Hospital, National University Hospital, and Tan Tock Seng Hospital during her training years. She's extremely dedicated in providing prompt and accurate diagnosis for her patients in a warm and supportive environment, and has developed a strong network in multidisciplinary care to deliver the best model of breast care. Dr. Tan also actively serves the medical community by sitting on the Singapore Medical Association Council since 2008, and she is the first female president of the SMA Council. I shall now hand the time over to Dr. Tan to share with us about screening for breast cancer in young women and special considerations for surgery. Dr. Tan, over to you.
Oh, thank you, Kelly, for the really warm introduction. Yeah, let me launch my slides for everyone. Okay, so today I would like to discuss the challenges of how to detect breast cancer in young women and the slight differences in surgical options. So some basic facts. I think most of the audience here would be aware that breast cancer is the most common cancer in women in Singapore and in fact throughout the world. And looking at the previously published data, we have almost 2,000 new cases per year. Due to Breast Cancer Awareness Month, I find that there's increased awareness amongst everybody, but most people maybe retain only certain information. So there's a lot of worry, and at least among my patients, some of them are worried for nothing. So I want to take today to have a chance to clarify some of the facts with you, destroy some of the myth and misconceptions. And also, I think educate the ladies below 40. So when young, what do we mean? No strict definition, but under 40 is young. So I'm very sad because I'm not so young anymore. Yeah. So if you look at breast cancer distribution, all right, the likelihood of people getting breast cancer, right, we go by roughly this kind of age group. This is Singapore data. You'll find that a majority will be in the middle older age, all right, 45 and above. But if we focus on the youngish group, right here, 45 and younger, about 20% of the age. So actually, it's not that uncommon, which if you look at the actual numbers and divide by the number of months and year, it's almost 30 young cancers per month, which is one young patient cancer is diagnosed per day. So I'm not sure among the audience here what kind of age group you are in, but some people assume that only old people get cancer. It's not true. Cancer can affect anyone at any age. It's just more common as we get older. So some basic signs on how cancer develops. If we zoom in on the milk duct, there's always a normal inner lining. And over time, hormonal change, this is a fairly normal kind of hormonal change called hyperplasia. The next stage is atypia, ADH, atypical ductal carcinoma. All these have the potential to develop into cancer cells. Then as they further mutate, it becomes DCIS, ductal carcinoma in situ. In situ means it's still within the inner lining. Then if left alone without treatment, it will progress further to invasive ductal carcinoma. Then from here, there's a chance that it can spread to lymph nodes and to other areas. So a lot of my patients come in only when they feel a lump, all right, whether it's 2 cm or 3 cm. At that stage, it's almost always an invasive cancer. This is the way that most ladies self-detect. So a lot of specialists will strongly advocate for mammogram screening. Our hope is that if we can catch cancer at a very early stage, where it's just these calcium spots, this could be at the stage where it's called atypia or DCIS. And that's why the importance of mammogram starting from age 40. There are some patients with very locally advanced breast cancer. When I get to know them better and we do a more thorough interview, I find that a lot of times it's due to a bit of neglect or denial or maybe an illogical fear that holds them back from seeking any treatment at all. My next slide shows some examples of what I mean by locally advanced breast cancer. If you are not familiar with some medical pictures, then just don't look for the next few seconds. So all these, the left two pictures are taken from the internet, the right two are my real patients. So thinking back, you see, the patient would have felt a lump maybe a few years ago. For the bottom right patient, she found a lump for about 5 years and she's aware that it's growing and coming through the skin with blood, a bit of smell. But what she did is to just apply a topical powder or tiambak, and when it got so big, she got her daughter to help her dress the wound. Along the years, her family sort of suspected something was wrong, tried to get her to see a doctor, but she refused, too scared. But you see, it's the fear is really not necessary, and that's what we hope this session will do, to help educate you what actually do we do in cancer treatment. And the earlier we detect it, the better the cure. Then a lot of patients will ask me, why do I have cancer? And there's all this conception, is it because I did something wrong, I ate dirty food, or someone cursed me, or is it just because of aging? The fact is it is multifactorial. The scientists have actually identified why a cell would choose to would mutate into a cancer. And these are all the very technical terms. Certain pathways are disrupted, and the cell keeps growing without control, and that's cancer. Now, all these are the risk factors that prompt that cell to change. So something very vague, right? General stress, whether it's physical, emotional stress, not sleeping enough, having too much fat in the diet, smoking, various toxins and chemicals add up, right? Our own body's genetics. So family history is important, relevant to know, not just for breast cancer, but any kind of cancer. Good to ask your parents, uncle, auntie, and just get a bit more information to share with your doctor. And there could be other risks that we haven't really identified yet. Yeah. So a lot of patients are very concerned, right, about, is there any way I can do to reduce my risk? For Chinese, there's a lot of food restrictions, but I think for Western medicine, honestly, there's no real food restrictions. All these unhealthy things, my advice is eat in moderation, right? Whether it's salt, sugar, caffeine, barbecue, kimchi, processed food, instant noodles, and all this. Having a little bit once every few weeks, every few months, it's not going to be harmful. I know a lot of people enjoy the taste, but of course, don't eat every day. Then definitely smoking is a very strong risk factor for any cancer. If you are smoking, please try to reduce and cut out completely. Alcohol drinking also reduce, like once a week. Red meat, yeah, not more than 500 grams a week. So maybe just 2 steaks, in a week, and then that's it. Now, the role of fiber, not so much for breast cancer, but good for colon cancer. Exercise is always good, right? Exercise helps to prevent weight gain, reduce all the heart attack, stroke problems, and prevents cancer. And even if someone has cancer, a person exercises in a stronger, fitter state. Yeah, and they'll recover better from the treatments. So how do you best protect yourself? Like I said, good to interview the family and find out a bit more. I find that a lot of Asian families sometimes a bit pantang or shy. They don't talk to each other. We see each other only once a year, Chinese New Year. Then now with COVID, we don't even talk to each other at all for 9 months. So, or they will always try to hide, oh, the person died of old age, but actually it was a cancer. So there's nothing to be shy about. Just to find out a bit more, what age did they get the cancer? Which part was it in? Yeah, and when you talk to a doctor, this is the kind of family chart that we try to construct to identify, how high is your current risk of having inherited a problem. Smokers must stop smoking. If you are able to, good to have a general health screening check for the height, weight, blood pressure, diabetes, not just for cancer, but for everything. Start making lifestyle changes, like a healthy diet and exercise. The role of social support cannot be underestimated, right? Whether it's having a good bunch of friends, good family support, to accompany you for the doctor's visit, just to give you some encouragement, whether it's for invasive procedure or not. Read up more, attend talks like this to improve your general knowledge. Most important is don't be scared, don't be afraid. Just come forth and get the doctor's opinion, right? If you're a good family doctor, that's the best, someone you're familiar with, and your doctor will recommend a specialist check as necessary. So what is health screening? Screening means the process of looking for a problem even when you feel fine, right? So for breast, it is a mammogram screening. Then for all of us, it's good to do a monthly breast self-examination. So some people have asked me, why do they need to check? Because they feel all right. So to recap, we want to look for early precancerous changes, especially the atypical group. Then if let's say it's a cancer, we want to catch it at a very early stage, the DCIS stage, right, where patients don't need chemotherapy. So early detection can actually prevent breast cancer, and early breast cancer is very treatable. So mammograms is the X-ray of the breast, standard recommendations for age 40 and above, and to do yearly when you're feeling fine. There'll be 2 views taken, top and bottom view and a sideways view, and what we're looking for is for the abnormal calcium spots. There's a lot of women who will try to explain why they don't like to do a mammogram, because they've heard it's very painful. The fact is, it is uncomfortable, but it is not a sharp pain. There's a lot of pressure, but there's no cutting feeling at all. And some people are worried about the radiation that is very harmful and toxic. The fact is the radiation dose is very low. It's just like normal background sunlight for about 7-8 weeks. So the overall benefit of detecting early cancer outweigh the risk of this little bit of radiation. And some say, I've done it before, why must I go again? Right? So just because you have one normal test doesn't mean you will never develop cancer. The purpose of a yearly check is to look for any new calcium spots and whether or not we need to investigate those. And this is the group of patients who are scared of something, right? They're scared that there's something abnormal. So the fact is not all abnormalities are cancer, all right? 9 out of 10 patients will have a benign or hormonal kind of change. And early cancer is very treatable. The Singapore government has a Breast Screen Singapore program, or the MammoBus, which does mammograms at a very cheap rate. And some patients go for that. What I see are that when there's abnormal result, they don't get much information. They get a letter to say this is abnormal, please see a specialist. And then the patients are understandably very anxious. So depending on the family budget, if able to see a doctor to get the mammogram done, definitely that will give you the best kind of reassurance. Then some patients go for ultrasound. So ultrasound is a different technology using sound waves, and it's good to study lumps. It's not able to pick up calcium spots. So here I show some examples of the lumps. Top right is a water cyst. It is smooth and oval in shape, inside is black. The second one shows a fibroadenoma. This is a benign non-cancerous lump, like fibroids in the womb. Same thing, is oval in shape. The inside color is a very even gray color. The last picture shows a cancer. It is very irregular. We can't quite see the surroundings, and it's so dense and heavy that it absorbs the ultrasound, so that behind there's a shadow. So sometimes for patients with a lump, I can do a basic ultrasound and have a pretty good idea what kind of lump it is. So this example shows a patient with a likely cancer. It's a very irregular mass, very irregular lump. And when we scan the armpit area, we can see that one of the lymph node is swollen. So this is likely a breast cancer. We've spread the lymph nodes already. So some patients, when they go for mammogram, the report was mentioned this thing called dense breast. What does that mean? Dense breast just refers to the breast tissue that's overlapping and looks very white. So you can imagine that white on white, right? The white calcium spot on white dense breast, sometimes it's not so well seen. And even the small cancer, 0.5 cm, cannot be seen so well. As we age, the breast tissue shrinks and it gets fattier. And the older we are, the more accurate is the mammogram. So for women with dense breasts, sometimes we add on the ultrasound. So then, how about for the young woman below 40 years old? Below 40, most of us will never subject you to a mammogram because it is too dense. So it's like no use. Everything is white. And we do have some radiation risk. So if we start mammogram at 30 years old, and then we do yearly until 40 and beyond, that's 10 years of additional radiation, which is not worth the risk, right? By most specialists' judgment. So for ultrasound, that's the only option we have. It is good for symptomatic young women, meaning that if you have you felt a lump, you have a nipple discharge, we use the ultrasound to investigate. The use of ultrasound as a screening means if you are fine, you have no problem, we use ultrasound to try to detect cancer. Most specialists are not so sure about that. It's very controversial because most times the lumps that we see are not cancer. Very small cysts or small lumps, fibroadenomas that cannot be felt by hand. And I find that some patients become very worried. How come they have 20 over lumps? And why is the doctor not worried at all? Yeah. Then for young women, some of them we do a MRI. This is again, I think need to let the specialist advise. MRIs are very costly, $1,000 over $2,000, and in a way it's oversensitive. If the ultrasound can see many small lumps, the MRI can even pick up abnormal blood flow. So you end up with a report where there's a lot of abnormal areas, and you'll find that most of these are not going to be cancerous. So among the specialists, we have some strict indications on which patients are suitable to have the MRI done. Some of the things that are being tried out, tomosynthesis is like a 3D serial X-ray or contrast enhanced mammogram. This is where there's an injection given to called contrast to try to enhance certain area, make certain abnormal areas look brighter on the mammogram. So all these are being tested. There's some role for it, but it's not proven to be better than a normal baseline mammogram. So specialist challenge is always, how do we help to detect that one young cancer patient, which is who is not suitable for ultrasound screening, for mammogram screening yet. So if you have any family history, or you find that you have some areas in lumpy, you're not quite sure, go to speak to a specialist to understand which is the best kind of scan to do to help you make sure you don't have cancer. Yeah. Then some people ask, can just do the screening mammogram and not the ultrasound, even above 40. So I want to emphasize again that mammograms and ultrasound, we're looking for different things. This one shows a maybe 3 or 4 centimeter breast cancer. It can be felt. This one shows a 1 centimeter breast cancer, which may be seen on ultrasound or mammogram. Now this one is likely a DCIS, which are just calcium spots. And this one, just a few calcium spots here and there would likely be atypical. So remember, the earlier we detect something, the easier the treatment. So does it mean that all lumps are cancerous? Of course not. These are all the possibilities for a lump that you may feel in yourself. Gynecomastia is for men. Some men have swelling of the breast tissue. Lumpiness, which most women have, is almost always hormonal changes, fibrocystic change, or a condition called sclerosing adenosis. Some ladies, they will form little water cysts once in a while. Depending on the shape, it's a simple or a little bit more complex, some hard lumpy area. Fibroadenomas are also very common, oval shape, a benign lump. Some of these fibroadenomas can grow really fast and become a phyllodes tumor. Then this one needs surgery. And some people have fatty problems. The fat died off, it became a hard lump. Some of the fat's a bit too oily and watery, becomes a cyst. Some form a solid lump like a lipoma. And some are skin lumps. Like this one is a kind of a pimple called sebaceous cyst. It just happened to be over the breast area. And then only one of all these is breast cancer. So when I see a patient with breast lump, these are all the different things I do to help decide is it serious or not serious. Bedside aspiration is just using a simple needle to extract a bit of the fluid or cell for testing. So these two pictures show this is an infection. All right, and we just extract some of the pus for testing. This is a lady with a breastfeeding infection with a lot of milk and pus stuck inside. Then for patients with a solid lump, they will need something a bit more certain, called a core biopsy. The needle is larger, and what we want to do is to extract a bigger piece like this for testing. The method of extraction, we can use an ultrasound to find the lump, or we use a mammogram, and that's called stereotactic guided. So for any patient with a suspected breast cancer, right, of course, in the clinic, after my assessment, I'll recommend the correct kind of imaging, whether it's ultrasound, mammogram, or even MRI. Then based on that, we do the necessary biopsy to confirm the cancer. Once it's confirmed, they will need to go for a whole body scan called staging scan to help us decide which stage they're in and to guide the treatment. Treatment for invasive breast cancer, very briefly, for stage 0, which is the DCIS group, they just need surgery. All right. Some of them, depending on which surgery they choose, may need a little bit of additional radiotherapy. Yeah. Then some, if the cancer is very sensitive to female hormones, just need a course of tablets to suppress their own natural hormone level, and there's no need for chemotherapy. For patients with stage 1, 2, and 3, depending on the actual kind of cancer, and of course discussion of pros and cons, some of them will go for surgery first, followed by all the other follow-up treatments, meaning chemotherapy, endocrine tablets, or radiation therapy. Some patients' cancer are more suitable for chemotherapy first. So chemotherapy takes place. Once the cancer has shrunk and is under control, then they see me for surgery. And once the wounds are healed, they actually follow up with additional treatment. For patients who have stage 4 cancer, meaning that at the point that they see a doctor, it's really spread, they undergo chemotherapy and some form of palliative care to make sure that all their symptoms are under control, so they continue to have a very good quality of life. So neoadjuvant chemo, the whole idea is to try to shrink a tumor. It is really very ideal for patients with a large cancer and they hope to still save their own natural breast. So this is a very nice example of an MRI scan for a patient before treatment, where the cancer could be maybe 6 or 7 centimeter big. If we try to operate on this lump straight away, I will actually need to take a very large area, maybe half the breast is removed. So the resulting breast becomes very small and very abnormally shaped. So if the lady wants to save her own breast, then it's good to go for chemo first, let the cancer shrink to a very small area, and then the surgery is a lot smaller and the patient can keep her own natural breast. So these are all the different kinds of surgery that can be done. Traditionally, it's a mastectomy where the whole breast is removed, ending with a flat chest. Some patients can accept it, and that's fine. Then for some patients, they choose for breast conservation or lumpectomy. So the cancer with a bit of surrounding tissue is removed. A separate cut is made in the armpit area to check the lymph nodes. Then such patients always need radiation to confirm that the cancer are unlikely to come back ever again. This one shows a mastectomy with reconstruction. What that means is we remove the nipple and the breast underneath but keep the skin. At the same time, a plastic surgeon may use the tummy fat and muscle or the back, or some patients opt for implant and put the shape back so that the patient feels like there's a very natural shape appearance. Then depending on the patient's natural breast shape and size, some ladies have very large and more droopy breasts. They are suitable for a breast lift procedure where the healthy side is also partially removed, yeah, so that there's a slightly smaller size and there's a bit of an uplift. Then the cancer side is also removed in the same way. During the same operation, I will also do a sentinel lymph node check that involves injecting a blue medicine that will travel to the first 1 or 2 guarding lymph nodes. Then this is what I see during the surgery. This is removed for testing to confirm there's no cancer spread. In the olden days, all patients had all lymph nodes removed, and there's maybe up to 2 out of 10 patients will end up with this kind of condition called lymph edema, because the lymphatics help to relieve some of the water swelling. And if the lymphatics are all gone, you find that the water swelling is not able to resolve by itself, end up with a very heavy arm. Thankfully, this particular patient, after some physiotherapy and hand massage and wrapping, arm managed to return to a fairly normal size. So cancer can happen to any of us at any stage with any kind of family background. So each of us must do our best to reduce risk. Do take charge of our own health, right? Go for general health screening and go for specific screening such as the mammogram, such as pap smear. That is good to attend talks, yeah, read more to educate ourselves, empower ourselves. I find that the modern day woman is very stressful with many roles, right? A lot of us try to have a career. Of course, we are a daughter. Some of us are married and got, become a daughter-in-law. Then we also have our own kids, or maybe for the older attendees here, we are really grandmothers. So I find that it's very important to not neglect yourself. Make sure you also look after yourself and go for checkups. I want to emphasize that breast cancer care is multidisciplinary. That's why most of our talks is not just by surgeon or by oncologists alone. It's a combined talk to talk about different aspects of the care. The nurses also provide very good support in the wound care, in follow-up the appointments. So do speak to your doctors and the nurses or your support group about all your different concerns, whether it's how to return to work, how to have a natural appearance. Then for the young woman with breast cancer, I think family planning intimacy is something very important, but maybe again our society or maybe with some doctors, they are not so forthcoming. It's important to share your concerns. Do you plan to have more kids? Do you marry and didn't expect you have cancer before you start family? How is the relationship with the husband like? So share your concern with the doctor and we can help to teach you what to expect and how to get around any problems. So my final slide, some take-home messages. Regardless of age, start your monthly breast self-examination. There's a lot of very good YouTube videos now on how to examine yourself. If you are age 40 and above, make sure you go for your yearly mammogram. Yeah, add on the ultrasound if you have dense breasts. For those under 40, speak to your doctor about whether or not you should have an ultrasound breast as a screening tool. If you have symptoms, you should see a doctor and let the doctor advise, do you go for mammogram with ultrasound or just the ultrasound alone? Remember, prevention is better than cure. And if we find it atypical stage, we can remove it so that it never develops to DCIS or invasive cancer. Early detection saves lives. So stay well and live well.
You. Thank you so much, Dr. Tan, for the informative sharing, especially on what to expect at a consultation or review with a breast cancer specialist. So if you have any questions for Dr. Tan, please key them into the Q&A box. I see we have a few questions in already. We will be addressing them later on. And of course, if you would like to book a detailed consultation with Dr. Tan, please, or to find out more about our Thomson Breast Center services, you can scan the QR code that you see on your screen or contact us and email on your screen as well. All right, moving forward, we're going to hear about what a breast cancer diagnosis could mean for young women. We know that it comes with psychosocial challenges such as navigating a career, body and self-image issues, fertility concerns, and all these could possibly be going through a young patient mind when going through cancer treatment as well. So to address some of these concerns, have our next speaker, Dr. Guek, who is a senior consultant medical oncologist at Icon Cancer Center. Hi, Dr. Lee. Thank you for joining us. Now, Dr. Lee specializes in breast cancer, specifically focusing on young women with breast cancer and research. She has a strong focus on research and has been involved in a number of Singapore studies and the setup of a national program for young women with breast cancer help increase awareness and education. For her work in breast cancer, she was awarded the International Fellowship NMRC Research Grant in 2016 to train as a fellow at the Dana-Farber Cancer Institute, focusing on young women with breast cancer and pregnancy-associated breast cancer. I should now hand the time over to Dr. Lee to share on breast cancer in young women and fertility preservation. Dr. Lee, please.
Ali, thank you for the great introduction. Let me start by sharing my screen. Okay, so it's the end of October, and we had quite a good October because it's the Breast Awareness Month, and we had quite a lot of talks going on and a lot of activities. So I hope you all had enjoyed this October and learned a lot throughout. So this is probably the last talk to recap because today is the last day of October. So my focus will be on young women with breast cancer and how to protect yourself. I think hearing from Dr. Tan, we already got the idea. We must empower ourselves, we must be vigilant, and we must take care of ourselves. So let's go into it. Basically, I am really interested in female cancer. So I do a variety of female cancer, including like breast cancer and gynae cancer. My specialty is focusing on young women with breast cancer and even like pregnancy-associated breast cancer. So with this, my scope today, I will touch on the burden of breast cancer, symptoms, risk factors. I will go through it very briefly because I think our first speaker has already touched on those. And also maybe we'll focus a little bit more on young women breast cancer, rounding it up with a case study and also some facts on fertility preservation, how to go about it, how not to be, intimidated by it. And then finally, some facts and myths. So I think this is not an uncommon graph. I think throughout the talks this month, we probably have seen, this graph multiple times. But I just want to highlight, breast cancer, as illustrated by this pink line, is really on the rise. And the incidence rate has really increased dramatically over the years. So if we compare like 70s to now, this number almost tripled. But I do want to focus on, some optimistic aspect, because while the incidence rate has increased dramatically, like the graph on top, we see that the mortality rate is more or less stable. And we think this may be in part due to breast screening, which really helps us to pick up early disease, which can then be totally curable. I think before going further, it's useful if we just look at the structures in the breast and get an idea of where exactly the breast cancer is arising from. So here we have a pictorial picture of this breast structure. So we know that the breast is made up of muscles, connective tissues, fats, etc. The part that really gives rise to cancer originates from the lobules as well as the duct which connects the lobules to the nipple. So basically the ducts are the structures which carries milk from the lobules which produces it to the surface, to the nipple. So the ductal carcinoma is fairly common and it accounts for maybe 60-70% of the breast cancers that we see. The lobular breast cancer is a little bit less common, but nevertheless it still accounts for about 10-20% of the breast cancer. So what are the common symptoms? I think Dr. Tan probably went through this and I'm not going to go through it in detail, but I just want to say that, we must be vigilant with our breast self-examination, because if we don't do it regularly at a regular interval, we are not going to pick up any of these changes. So the other thing is, of course, when you pick up any of these changes, please do not be alarmed. Just seek medical attention, because not all of these changes are associated with a cancer or malignant condition. It could well be a benign condition. So next, I want to touch a little bit on the risk factors. We have conveniently dichotomized it into modifiable and non-modifiable risk factors, mainly because this really helps us to actively zoom in on the factors that we can work on, that we can modify our lifestyle and improve our risk factors with regards to decreasing breast cancer risk. So what are the modifiable risk factors? Basically, it is sedentary lifestyle, obesity, alcohol consumption, smoking, and also taking hormones in the form of hormone replacement therapy or certain types of oral contraceptive pills. The non-modifiable risk factors are things we can't do anything about. We are female, we age, and then some race as well as the strong family history is typically associated with BRCA1 and 2. Those are things that we can't change. And also some factors such as early start of menstruation and late menopause, predominantly because it really exposes our body to female hormones that will increase the risk of getting breast cancer. The same rationale for delayed or no childbearing, because there's no interruption to our menstrual cycle. And also for some patients, if they have had childhood disease that require chest irradiation at a young age, and that can predispose to breast cancer at a later part in life. So what can we really do, right? I think we need to exercise. We are not here to be your trainers and drill you into a regimen, but exercise is really important. And try not to drink or drink at least in moderation, quit smoking, try to maintain a healthy weight. So if we look at, advice from WHO, they really recommend moderate intensity aerobic exercise up to 150 minutes a week, and also muscle strengthening exercise 2 times a week. So if you divide 150 minutes into 5, you need to exercise like 5 times a week for at least 30 minutes. And in fact, this is also not easy, like for me, because I try to exercise regularly, but it's a bit difficult to hit 5 times a week. So what do we do and what can we do? So this is one of my picture when I went for a Tour de Mont Blanc. So basically it's a trek that spans 3 countries, Italy, France, Switzerland, beautiful scenery. We trek from 8 a.m. to about 5 p.m. daily for 7 days. So I think what we can really do is to find something that we really like and also do it with a group of enthusiastic people and people whom we can enjoy the company. That's the easiest for me. So these are some pictures, beautiful sceneries, again, euphoric faces, that's what exercise do to us. So I think the best way to do something to get into a habit is to exercise regimen I'm talking about, is to do it with people you like and to enjoy it and find something you're interested in. So let's take a look at this American Institute for Cancer Research cancer prevention recommendations. I think most of these factors are things that we spoke about already, but I think they went into more details. So basically, eat a diet rich in whole grain, vegetables, fruits, beans, limit your consumption of fast food and processed meat, especially red meat. Also limit consumption of sugar or sweetened drinks. I will touch on this a little bit more later on. And also, do not over supplement, cut down on alcohol. For cancer survival, you have to follow a surveillance protocol. So breast cancer screening, very briefly, because Dr. Tan has already mentioned it, we have a health screening program. So it basically starts above the age of 40. But for younger women, especially if you have a significant family history or even personal history, please do talk to your doctors so that you can be, advised based on when to start and how frequently to do it. And really, it's all about mammography as well as breast self-examination. So the mammogram, I think, already gone through, but I think I just want to give some tips. Some women are very scared of mammogram. Basically, it's an X-ray picture. The painful part is when your breast is squeezed between the 2 plates. but generally it is very fast. So I think some tips to make it less uncomfortable, maybe to do it, not during your period, because during your period or perimenses, your breast can be very tender, very lumpy. So that makes it a bit more sensitive and painful. So try to do it after your period and try not to wear perfume or deodorants because it can affect the image. So next, let's talk about young women, this population under 40 years old, right? So if we look at the statistics, then we can better appreciate why, in Asia, we really focus on this population less than 40 years old. Because in Asian population, if we look at the registry, the proportion of women with breast cancer below 44 years of age makes up about 19%, and this is not a small figure. If we compare it to the Western population, less than 40 years old, they have about 4 to 7%. So this issue is actually a big one in Asia. And we see, Korea or even Japan, basically Asia has a huge proportion of young women with breast cancer. So coming to treatment principles, the treatment really do not generally differ that much from older women, but because we still treat according to the biology of the disease and the stage of diagnosis, we follow the treatment principles based on this. But I think for younger women, we must always give a lot of consideration because of the numerous psychosocial issues that they face. So what are the examples? You see, when they are young, they could be starting a young family. They could be at the peak of the career. They could be juggling work and young family. And if they are young enough, they may still be paying off loans for their university education. And also they may face substantial peer pressures because understandably their peers are at a different stage of their life, and hence they may get, sexuality, fertility, relationship issues, and body image and self-image issues when they compare with their peers. And all this will all accumulate and affect their adherence and compliance to treatment. Last but not least, important issues such as fertility and hereditary disease are main considerations for these patients. So when we talk about treatment for these patients, some things that may add additional stress to young women because, their hormone drives are usually higher, and during treatment, we may have a need to suppress their hormone drive. Hence, they may have more pronounced side effects. So they may get more difficult side effects such as hot flushes, mood change, depression, insomnia, weight gain, etc. So we must always be very sensitive to this group of patients because they may behave differently from older counterparts. So they need a lot of psychosocial support, family support, as well as peer support. So for treatment, just now I already mentioned the treatment is not totally different from older women because we focus on the biology as well as the stage of diagnosis. But in younger women, what we are seeing is because, sometimes for younger women, they have a lower index of suspicion because when they have a lump, they may feel that, this can't be cancer, I'm still young. So for some women, when they see a doctor, the cancer are already usually larger. And for some cases, they may be more aggressive as well. So the treatment may more frequently involve what we call neoadjuvant chemotherapy, meaning the systemic chemotherapy are given before surgery. For chemotherapy that are given after surgery, we call it adjuvant chemotherapy. So for these women, more often we see the use of neoadjuvant chemo compared to adjuvant. So I think it's easier to put things into perspective if I have a case study. So this is actually a case that I treated. She was really young, 30 years old. And incidentally, she just got married a month before the diagnosis of breast cancer. So by the time she saw me, she already had a 4-centimeter breast cancer. Using the lingo of breast cancer, she was hormone receptor positive because the estrogen receptor was positive. And she has a positivity in one of the other receptor called HER2 receptor. So, she saw me, she was fairly distraught because she just got married. Initially, she didn't want any fertility treatment because she was telling me she just wants to get it over and done with. She just wants to start chemotherapy as soon as possible. But we talk about it after a lot of reassurance, and using modern technique, I could share with her that embryo cryopreservation basically can be completed in 2 weeks now with modern techniques. So in the end, because she have only just gotten married, so she decided to go and see a gynae. In fact, everything got sorted out very promptly, and she did embryo cryopreservation. She was started on the hormone stimulation the next day, and she managed to complete the whole process within 2 weeks. And that's very timely, because after that, we could immediately start her chemotherapy within a span of 2 to 3 weeks. So this is not a major feat, because if you compare it to olden days, they probably need to take up to a month for embryo cryopreservation, but now we could do it in 2 weeks. So I'll come back to this case towards the end. Let's move on with fertility preservation as a topic. So why is this important? I think it's very important to recognize that early stage breast cancer patients, they can live a very long life. So in fact, our statistics shows that for stage 1 breast cancer patients, they can have a 5-year survival rate of 90%, and this is really a very good number. So it's very important for us who are treating physicians to look at the patient, beyond the breast cancer treatment and diagnosis. Sometimes, the patients, when they are in the situation, they can't really see it. So we have to be able to see it and ensure that we want to ensure a good quality of life for the patients and talk to them about it. So we really want to help them to fulfill their lives, to pick up of their lives after the treatment, to let them, guide them towards a fulfilling life of getting married and having kids. So basically, young survivors, they have years ahead of them. So when we talk about fertility issues in young women, first of all, we need to establish, where they are in their family planning, whether it's completed. And usually we need to work together in a multidisciplinary team. We need to get the gynae or obstetrician involved, and they need to be thoroughly assessed by them. So some of the common questions that they usually ask will be, can I check my fertility level before treatment? How will age affect my fertility? What are my chances of getting pregnant after treatment? And how can I try to preserve my fertility? So I think to answer this question, it will be easier, to have a background for fertility. So we know that women are born with a fixed number of eggs, and this number declines, including the quality. The quality also declines with age. So by the time when menopause sets in, about 50 years of age, the ovaries essentially stop releasing eggs. So when we talk about chemotherapy and the likelihood of subfertility, we need to determine, what are the types of drugs used, what are the dose given, what is the current age of diagnosis, and what was the fertility level before treatment. And then we need to, plan together with the patient and ensure that they can get the fertility treatment before the systemic treatment for breast cancer. So in Singapore, we do like embryo cryopreservation as a gold standard, but by Singapore law, this is only available for married couple. So for singles, they can opt for oocyte, which is egg freezing, and also other methods include like ovarian tissue preservation as well as ovarian suppression. Last but not least, I think an important topic for young women will be the possibility of BRCA1/2 mutation carrier. So we are not unfamiliar with the Angelina Jolie effect. Basically, she was diagnosed to be a BRCA1 mutation carrier. So really for genetic counseling, it is not a simple procedure. It usually requires multiple consult. We need to talk to the patient and counsel the patient pre-test and post-test. And if it's a positive result, we have to go on to talk about risk-reducing surgeries. So this is just a cartoon illustration that says that it is not a simple consult. It will usually require multiple discussion, and hence we must give time for that. So to continue with the first case, the case study that we mentioned, so basically for the patient, it was very timely because her genetic results came back in time. And at surgery, she decided for double mastectomy with immediate reconstruction because she was diagnosed to be a BRCA1 mutant carrier. And subsequent to this, she successfully completed her adjuvant treatment. She finished up her chemo, she finished up her hormones, And at 35 years old, she told me that she wanted to have a child. So, she underwent embryo implantation and she successfully gave birth. So she's a good story. And after that, after she gave birth, we further went to discuss, removal of the ovaries in view to prevent ovarian cancer. So I just want to highlight young women, basically, they have multitude of problems and we do recognize that. Hence, I have developed a women cancer program in my institution, and we do provide, a step-by-step approach where we guide the patient through, all these important psychosocial issues, fertility issues, medical issues at every juncture. And we are there with them, and we even have access to a support group. So lastly, I just want to touch a little bit on common breast cancer myth. I think, probably Dr. Tan covered a little bit, but these are just some of the common myths that I want to touch on. A lot of them are associated with a false sense of security. For example, some women may feel that as long as I exercise, lead a healthy lifestyle, I don't have to worry about breast cancer. And also, as long as I go for regular mammogram, I'm safe. And also, my family has no history. Why should I be worried? So I just want to say that, while family history and strong and genetic mutation is a common factor, sporadic cancer, meaning cancer that arises, in a young woman or in women, can be common as well. So do not take for granted. Always be vigilant, okay, and go for your screening regularly. So consuming too much sugar causes cancer. This is a myth that I want to touch on. And also WHO recommends not to take too much sugar, right? Basically, the link between sugar and cancer is not a direct one, but it's indirectly, because if you consume too much sugar, it can lead to obesity. And we do know that obesity predisposed to 13 other different types of cancer. So this is something which we can actively modify to reduce our risk of breast cancer. So to end, I urge everyone to stay safe as well as stay positive, because, in recent years, there are really a lot of drugs for breast cancer being developed, and we are seeing really a better and better cure rate. So if there are any other questions, we can take the questions together. I will stop my sharing here. Thank you.
Thank you. Thank you so much, Dr. Lee, for the insightful sharing and the positive messages of hope for all the patients out there as well. So if you would like to book a detailed consultation with Dr. Lee, please contact us using the clinic, using the number and the email that you see on the screen, or you can scan the QR code as well to find out more about Center's cancer program as shared by Dr. Lee. So we do have our Q&A segment coming up. Thank you for your enthusiastic questions. We have quite a number, of 4 to 5 questions. So let's try to cover them in the next 5-10 minutes or so. All right. So first question that I see here is regarding genetic mutations. Can we have both the doctors on the screen? Let me see. As well. Thank you so much. Okay, so the first question that we have is from Leo regarding genetic parallels of BRCA1 versus BRCA2. So is one of them worse off as the one of them worse than the other? And what is the differences between BRCA1 genetic parallels versus that of BRCA2 genetic parallels? Can we have Dr. Tan to answer that first, followed by Dr. Lee, please?
This question I fully defer to Dr. Lee, because as a surgeon, we actually, I know those much counseling. Yeah, that's why I think Dr. Lee, as an oncologist, they will be performing the genetics testing. Yeah.
So basically, the BRCA1 gene and the BRCA2 gene, they are, genetic hereditary syndromes that predispose any individual to breast and ovarian cancer. So I think Leo probably asked whether, I think what he's trying to ask is right? Sorry. What he's trying to ask is whether, one is worse than the other. basically they predispose slightly to different cancers, but the most common ones are breast and ovarian. And also in males, it can cause, prostate cancer. It can even cause pancreatic cancers and melanoma, which is a skin cancer. But if we talk about, lifetime risk of breast cancer and ovarian cancer, indeed, BRCA1 gene is associated with a higher lifetime risk of breast and ovarian cancer. So for BRCA1, we are talking about probably, a lifetime risk of up to, 70-80% breast cancer risk, and BRCA2 maybe, slightly less, anywhere from 50 to 70%. For ovarian cancer, BRCA1 can give, a lifetime risk of up to 40-50% ovarian cancer risk, and BRCA2, a little bit lesser, maybe 20-40%. So the range is quite wide, and also it's a bit different because it depends on some literature. They consider lifetime risk up to 85 years old, and some literature consider lifetime risk up to 70 years old. But we do see that BRCA1 generally is associated with a higher lifetime risk of breast and ovarian cancer compared to BRCA2.
Thank you, Dr. Lee. So in conclusion, yes, BRCA1 is typically more aggressive, has a higher risk compared to BRCA2. So we're going to move on to the next question. All right. This is a question put forward by Christine. So Christine is relatively young. She's less than 40. She has no symptoms and no family history of breast cancer. So upon consultation with her doctor, it was said that she does not require any form of NRI or ultrasound or mammogram at the moment, except for regular self-screening, regular BSE. So she says that listening to the talk, it looks like there's no other ways to check besides self-examination. Is that right? Can I just want to ask Dr. Tan and both Dr. Lee, Dr. Tan and Dr. Lee. Dr. Tan, please.
This one I have to, how should I put it? I have to educate and reinforce. For the average well person, there's no need to deliberately go and check for breast cancer and go for ultrasound. You see, so I know today's talk is on breast cancer, but you see, I don't know whether people here are aware that there's also colon cancer and there's a lot of other cancers. And it's always a balance between doing a test to look for early cancer versus letting the cancer form. So for breast, we want to balance the risk of early checking versus missing a diagnosis. So emphasize again, at 40, mammogram screening is proven to be helpful in detecting early breast cancer. Any age younger than that, there's really no need to randomly go and do a check. Yeah. So for colonoscopy screening, let's say for colon cancer, we actually ask patients to start the colonoscopy only at age 50. All right. But again, depending on diet and all that. So patients with symptoms need to have a check. Patients with no symptoms or otherwise, well, there's no need to actively go and look for it. So that's why when Christine phrased the question, listening to a talk, there's no other way to check. I don't quite understand. You check your own breast. The monthly breast health check is very important because over time you would know your body best, and any new lumpiness, thickening or hardening, skin dimpling, or nipple discharge, like a bit of stain on the bra. All these are symptoms, and then that prompts you to get the doctor's evaluation. If you check every month and everything feels normal, looks normal, then there's no need to get ultrasound just to check. Then of course, if you are all Singaporean, understands English, if you are very kiasu, right, then of course you pay the money to get the ultrasound done. But if the ultrasound is normal, then very good, right? If the ultrasound shows 20 over lumps that are 2 or 3 millimeter in size, then what next? The doctor, I will always tell patients, these are benign, leave them alone. But most patients cannot accept it. Most patients will be very obsessed and harassed and scared of the 20 over lumps because they just cannot believe that, lumps can be non-cancerous. Sorry, I sound very passionate and aggravated, but I see this confusion day in, day out. And if a lump is not cancer, it is not harmful. And 9 out of 10 lumps are non-cancerous. I hope the audience can really appreciate this distinction.
Thank you, Dr. Tan. Dr. Lee, would you like to add on?
What do you think?
Oh, okay.
Yeah.
Thank you, Dr. Tan. Dr. Lee, would you like to add on?
I think what I just really want to add on is that, you still have to be vigilant and do breast self-examination. We are not asking everyone with no family history. Basically, we divide it into population risk and increased risk. So if you don't have a family history and no symptom, it doesn't mean that everyone should go out and start asking for a mammogram, because it still have some radiation, right? So what you can start with is to be vigilant. Just do your breast self-examination, and that will ensure that if there's anything, any abnormality, you'll be the first one to find out, and you can pick it up at the earliest and soonest possibility and present it to your doctor. So this is something that we can do for ourselves.
Can I just share one very recent example, and that will explain why I'm so passionate and emotional about this topic. I have just diagnosed a young 34-year-old lady with advanced breast cancer. All right, and I'm feeling very sad and disappointed because the lump is 5 centimeters in size. It is hard. It is like a rock. She had just delivered her baby when the ward lactation nurse found that there's this hard lump. So when I met the young lady, I asked her, do you notice the lump before? Then she pressed and pressed it. Is there a lump there? I'm not sure. I think it's been there. For how long? For 2 months. So the more we talked, I found that she was in the group of ladies who are in maybe a bit of denial. During pregnancy, she was told that there will be hormonal change. So she assumed the swelling was hormonal change. Number 2, when she found the lump, she assumed it is normal because she's young. She cannot possibly have cancer. Number 3, even when I told her that this is worrisome for cancer, her mind instantly rejected it. No, cannot be, because I am young. So you see, I think the fact that all of you are here today on a Saturday afternoon to listen to the talk shows that you ladies here are aware and you all want to know. But take this chance, take these messages and talk to your friends, talk to your family, your colleagues. Are they as aware as you about breast cancer? People, I think Dr. Lee will and I agree, people who come for breast cancer awareness talk are usually very on the ball one, right? They are sort of aware of breast cancer, they understand screening, they want to know. But there's a huge population out there who may be a bit scared, or think it's a waste of time. I'm fine, no one in my family has cancer. Cannot be that I have cancer. I don't want to waste my time listening to a talk. And these are the group that sort of delayed their presentation and treatment. So if you are here, that's already fantastic, and you're learning a lot of tips on how to protect yourself. Help us to spread the message on and educate others in your immediate circles and family.
Thank you so much, Dr. Tan. I hope that that also answers H1's questions. We have about 5 minutes left, so we're gonna try and answer about 2 to 3 more questions as much as we can. The doctors, if you see the questions that are in the Q&A box, if you would like to answer them by typing them in the Q&A box, that would be fine as well. So that was the question by H1 as well as by Christine. So we also have another question here that says that that's about breast atypia. All right. So one of our attendees have asked that breast atypia greatly increases future risks. Are all breast atypia the same? And is there any way to minimize it from developing into breast cancer? Also, we have Prischel here. She's 24 years old and she's recently diagnosed with atypical ductal hyperplasia, and her mother has been diagnosed with stage 0 breast cancer at 40 plus. She also would like to inquire about what are her risks of developing breast cancer. Let's start with Dr. Lee for these 2 questions, please.
Okay, so I think for the breast atypia, probably Dr. Tanya Swam will be the best person to discuss that. And also for the individual question of atypical ductal hyperplasia and personal risk assessment, I would advise the patient to probably seek a medical consult with us. So Yasmin, you want to talk about that?
Yeah. So atypia, if your doctor has given you your lab report, any kind of atypia has increased risk of breast cancer. The actual percentage depends on which special study that the doctor will quote. It may be as much as 8 times to even 20 times increased risk. And that means lifetime risk. Means that a person of your age, your other risk factors being equal, the person with atypia is 20 more times more likely to develop breast cancer compared to someone who didn't have atypia. So if your biopsy showed atypia, most surgeons will advise a minor surgery to remove that area to ensure there's no remaining atypia. That's one. Number two, your doctor should be advising you to stay on lifelong follow-up with the specialist directly in case you develop a new tiny lump or new abnormal calcium spot, and then the surgeon will need to intervene a bit earlier. There is some discussion as to the role of taking the anti-hormone tablet for cancer on patients with atypia. Yeah, but I think it's a very controversial thing because those medicines have a lot of side effects. And as of now, most of the doctors, oncologists I work with will not prescribe it for patients with atypia. We just keep them on close monitoring. Yeah, so I hope that helps. For Priscilla, I think, yeah, as what Dr. Lee said, it would be good for you to see maybe Dr. Lee or any other oncologist that you wish with your mom, because it sounds like you and your mom would be suitable for genetics testing, right, Dr. Lee? Yeah, because of the very young onset.
Yes, I think we can certainly discuss this probably as a more private consult.
That's right. Yeah.
All right, I think that's about all the time we have. I know that we do have one more questions. That's from Asji, but we will try to take that offline as well. So thank you all so much for participation. So do take note, all right, as you can see on your screen, we will be the contact details of both Dr. Tan and Dr. Lee. Can we have the contact details back on the screen, please? So if you do suspect that yourself or your loved one may be experiencing abnormal changes to your breast or any of the symptoms that the speakers have shared about, please do seek medical help early, all right? As both doctors have shared, breast cancer can be highly treatable when detected and treated early. So before we go, please take note of the contact details of both the doctors if you would like to have a detailed consultation with them one-on-one. Okay, so up next, you can see that on your screens, we will be conducting a simple poll to get your feedback about today's program. Please just take about 30 seconds to complete it before you go. And with that, thank you so much, Dr. Lee. Thank you so much, Dr. Tan as well. Thank you so much. And thank you all for attending our webinar today on breast cancer in young women, what you need to know, proudly organized by Thomson Breast Center and Icon Cancer Center, supported by our event partner, Pfizer. My name is Kelly. Thank you for commemorating Breast Cancer Awareness Month with us. Have a great weekend and see you again. Thank you. Goodbye.